Good morning, everyone. We'll start the session now. Welcome to Neurology Grand Rounds. It's my honor to introduce our speaker today, Dr. Justin Choi, who will be sharing with us his expertise on carotid artery surgery, an important, constantly developing field within vascular neurology. Dr. Choi is Assistant Professor of Surgery here at Downstate. He obtained his MD and completed his residency in surgery at Baylor College of Medicine, followed by a fellowship in vascular surgery at Georgetown University. He was assistant professor in vascular surgery and endovascular therapy at Baylor before joining us here at Downstate in 2022. Dr. Choi has published numerous peer-reviewed articles, abstracts, and book chapters, and serves as a reviewer for several journals. He's highly interested in quality improvement and is currently involved in multiple QI initiatives at our hospital. This includes developing a multidisciplinary group to reduce leg amputations and leading other collaborative initiatives to improve patient safety in surgery. He's also developing a hospital-wide PERT, otherwise known as Pulmonary Embolism Response Team. Dr. Choi is also passionate about teaching and mentoring students and residents towards a career in vascular surgery. Without further ado, I would like to invite Dr. Choi to address the audience.
Hi, good morning. Thank you for an introduction. Thank you for having me. I'm relatively new here at Downstate, less than a year, but when I was making this talk, I was trying to decide what was best, and I figured it'd probably be more interesting to talk about, the background of how, the carotid surgery became a field and how we got here. How do I just hit next? So I have no conflicts. I do promise that I'm not going to show too much data. We can always talk about it, but again, I'd rather just talk about what we do and what we can do. A lot of this talk will be focused on how we manage atherosclerotic disease, but that's not limited to what we can all manage with carotids. We can manage lesions related to fibromuscular dysplasia, patients with kinks and coils of the carotid. As you can see here, it looks almost like a pig's tail, and even larger lesions such as aneurysms, dissections, and carotid body tumors. So my boss isn't available today, but he's Greek, so he'd be proud of this slide. He always talks about how everything comes from the Greeks. The association of carotid disease and neurologic dysfunction has been understood for quite some time, dating back to about 400 BC when Hippocrates coined the term apoplexy, which was basically used to describe stroke-like symptoms. And he gave a conclusion that lesions of the carotid could possibly lead to hemiplegia. And not too long after, Rufus coined the term keros, which is where the word carotid comes from, and he noted that compression of the vessels could lead to loss of consciousness state of stupor, and it's depicted here in one of the metopes of the Parthenon, where a centaur is effectively compressing a warrior's neck or carotid. Not a lot happened for another 2 centuries or so, until Swiss physician Wepfer essentially provided first meaningful description of cerebral vasculature. In terms of medical literature, this is probably one of the first known references to associate pathological changes in the cerebral vessels and symptoms of cerebral ischemia. So no surprise, the first operation of carotids were essentially limited to ligation procedures. Many of them were for bleeding or for trauma. The first documented procedure was a ligation of a common carotid laceration to the neck by a sword by French surgeon Ambrose Père. And if you go back and look in the literature, he's pretty much ligated every blood vessel in the body and probably written about most of them. However, and there are further other ligations, either for bleeding during hemorrhage, bleeding for hemorrhage during tumor resection. And again, another British surgeon in 1800s who published the first successful ligation for another stab wound to the neck. However, many of these attempts were fraught with many complications, high rates of stroke and death. And it wasn't until the early 1800s when Sir Astley Cooper attempted to ligate a common carotid aneurysm in a 44-year-old woman. She initially did well, but she developed a post-op hemiplegia and death. And this is about when Dr. Cooper discussed the possibility of stroke after carotid ligation. He was so convinced that she would have survived had she been a better candidate and an aneurysm wasn't as large. So he tried again. About 3 years later, he met another gentleman with a much smaller aneurysm, who he quoted was of strong mind and vigorous frame. And he ligated the aneurysm, and the patient survived about 13 years after surgery, never without any stroke-like symptoms. This was how many carotid lesions were managed for the next century or so. Not surprisingly, the morbidity and mortality rates were quite high, nearly 50%. Towards the end of the 1800s, early 1900s, a physician reported a compilation of 600 cases with a mortality rate of over 40%. Thankfully, times and techniques have changed, and like so much in vascular surgery, a lot of this began at the beginning of the 20th century. We have to go back and give credit to physicians like Chiari and Hunt. They essentially described the pathophysiology for cerebral embolism and from the carotid artery and symptoms of TI and stroke. And another physician about 10, 15 years later was Antonio Muniz, who reported the first cerebral angiograms by direct puncture of the carotid. However, these descriptions didn't really take off, mostly because the studies for Chiari and Hunt couldn't be corroborated with cerebral angiogram. And when Muniz started doing his angiograms, they're considered to be quite dangerous. They're fraught with complications, either with postoperative bleeding, stroke, extravasation of surrounding tissues, and many of the experiments were with numerous contrast agents, including air. It wasn't until the 1950s when Carl Miller Fisher really kind of connected everything with he basically with the cerebral angiogram, he definitively outlined the clinical picture of atherosclerotic lesions and identified several cerebral syndromes. He noted that in many of his stroke cases that he did autopsies on, that there were very few embolic sources, leaving only the carotid bifurcation as a culprit. And he went so far as to suggest that surgical correction could be possible. And this is about when the race took off to see what could be done for occlusive disease. So establishing a chronology of the first interventions, who did what first, and who deserves credit for operating on the carotid for occlusive disease is a matter of semantics. It's dependent if you want to say if the surgery was done for asymptomatic or symptomatic disease, whether you look at anastomosis and resection or endarterectomy, which is what we do today, and the outcome of the procedure. And also some of the studies were not published until at later dates. The first noted endarterectomy was done and published in 1953. However, it was performed on a patient who had 100% occlusion of the carotid. And even during the endarterectomy, there was no flow. So they essentially ligated and resected the carotid bifurcation at that point. The first published reconstruction was done in 54. And this was again a resection of the carotid bifurcation with anastomosis between the internal carotid and the common carotid. And the patient lived for about 20 years without any evidence of neurologic dysfunction. But the first successful reconstruction was done in 1951, but wasn't published till 4 years later. Again, similarly with anastomosis between the internal carotid and the external carotid. And again, the patient lived for 20 years. In terms of who did the first carotid endarterectomy, it's a little bit less clear. But I'm from Houston and I'm from Baylor. And so it's been always kind of fun to grow up around the drama between Dr. Cooley and Dr. DeBakey. Not too sure how many of you guys know, they had about a 4 to 5 decade long drama or rivalry between two very, very pioneering cardiovascular surgeons. Dr. DeBakey claimed he did his first carotid endarterectomy in 1953, but didn't publish it till almost the 70s because he claimed that he wanted to wait for to follow the patient, whereas Dr. Cooley claimed he did it in 1956. There have been several letters and documentations and trading of operative reports, but for the most part, everyone credits Dr. DeBakey for the first successful carotid endarterectomy. And he had a very favorable outcome where the patient died nearly 20 years later with a neurologic exam. And how he performed the procedure is the basis of how many of us now perform carotid endarterectomies. Many of us close the carotid with a patch. He did a primary closure. And it wasn't until 2007 when Dr. DeBakey received his Congressional Gold Medal of Honor for his innovations in developing the VA and MASH units, that the two essentially made peace and they awarded each other into their societies. So after Dr. DeBakey performed the first carotid, the rates of carotid endarterectomies skyrocketed. In the early 70s, it was about 15,000 per year, and nearly a decade later, it was about 80,000 a year. The concern, however, was the complication rate. When their first retrospective studies looked at over 200 consecutive patients, and they had a mortality rate over 20%. During this time, surgeons knew carotid endarterectomy provided a benefit to patients, but it was unclear which patients should undergo surgery. It became such a concern that a study in the late 80s showed that nearly a third of carotid endarterectomies performed in the US were for inappropriate indications, whether it was for minimal stenosis of carotid, 100% included, or for patients that were not symptomatic. And so during the 80s, the rate of carotid endarterectomy dipped, due to the high rate of complications. And it wasn't until the late 80s, early 90s when the randomized controlled trials came out showing the benefit for carotid endarterectomy. And these are 4 of many, but NASCET, ECST, ACAS, and the VA studies began to clarify the level of stenosis and degree benefits for risk carotid endarterectomy and laid the groundwork for how we perform the procedure today, which actually our society guidelines were just updated about 2 years ago. This is one of the most intensely scrutinized surgical procedures that has been published. There is no right or wrong way to do a procedure. We can either do a eversion endarterectomy, where we essentially transect the internal carotid off the common carotid artery and essentially peel the artery off like a sock and remove the plaque and perform anastomosis. The classic way, where we make an arteriotomy and remove the plaque and sew it with a patch. And even then, how we do that has been up for debate. There are several patch materials that have been used, and they have been found to make no difference. The only guidelines that our society provides is when to do it and which procedure is better. For asymptomatic patients, they still recommend 70% stenosis, with an open carotid being the best possible procedure. And even for symptomatic patients, we still prefer to do open carotid endarterectomy over stenting. And for probably more relevant to how we interact with y'all is for patients with recent strokes. We generally try to perform the procedure within 48 hours to 2 weeks. And again, we prefer to do a carotid endarterectomy rather than carotid stenting. There are indications for carotid stenting, which we can discuss later, but still to this day, the gold standard is an open carotid. During this time, carotid angioplasty became more popular. Again, the first carotid angioplasty was done by DeBakey's group. It was an open angioplasty for patients with fibromuscular disease. And essentially, the classic procedure is an open dilation where we make an arteriotomy and we pass dilators up the carotid and pull it back. The first percutaneous angioplasty was done by Matthias. However, there are several complications, mostly dissection and plaque dislodgement. And it wasn't until the mid-90s when Marx did the first carotid stent for dissection and postulated that the stents could be used with angioplasty to avoid those complications. Again, there have been many studies, and the main ones that we still work with today are the Sapphire and the Crest studies. And basically, the carotid stents are favorable for patients with high risk. And depending how you want to interpret the data, the primary endpoints of stroke, MI, and death are nearly equivalent. However, there is a slightly higher frequency of stroke in stenting and a slightly higher frequency of MI in carotids. The argument behind interpreting that data is the quality of life after a stroke compared to MI, and which is why many of us still prefer to do open carotid endarterectomy. And so how we do the stenting is the classic way is through the femoral artery, where we access the common carotid artery and shoot an angiogram, and we identify our lesion. We then pass a filter to protect this for distal embolic protection, and we do angioplasty, and then we deploy a stent. And here you can see our completion. The newest technology out now and the hottest topic is transcarotid artery revascularization, where it involves making a small incision at the base of the neck and directly accessing the common carotid artery and passing a filtration system that works from a high flow to low flow system and returning the blood to the via the femoral vein. These procedures are about 30 minutes long. They're very simple. And they're low risk. And the biggest topic now has been whether or not it's better to do transfemoral or TCAR. The data has been supportive of TCAR, and with nearly about a two-time difference between in-hospital neurologic events. It's a short talk, but I figured if you guys want to talk, I can talk more about the techniques. But that's what I want to talk to you guys about today for the history of carotids. Happy to open questions.
Justin, I would just like to add a little bit to the history with C. Miller Fisher. I think what prompted him to make that connection between the neck and the brain was his bedside observation when he was doing fundoscopy, and he saw emboli going through the retinal arteries, and that made him, put two and two together. So, for the residents, I think it's an important learning lesson that simple clinical observation can lead to major breakthrough in treatment of disease.
I have a question. You mentioned that the best timing for surgery is beyond 48 hours, but earlier than 14 days. But I've seen cases in which the surgeons will not operate before 2 weeks. Do you have any thoughts on that?
So there are some studies that have mentioned the 2-week cutoff, but the risk of restroke is higher, and the risk of we really just try not to delay the procedure as much as possible. I would argue that most of the data for us support within 2 weeks.
Is there any role for digital subtraction angiogram these days?
Pardon?
Is there any more role for digital subtraction angiogram, or can we proceed to surgery without it? Just with a CTA or
a CTA? So it depends who you talk to. There are many groups that will do a endarterectomy purely off a carotid duplex. But a lot of it's dependent on sonographers on whether or not they can identify where the carotid bifurcation is. And why that matters so much for us is it kind of helps us plan if we need to do alternative measures to get a higher exposure. However, again, it's really dependent on your sonographer and whether or not they can identify the location of lesion. The nice thing about a CTA also helps us identify other lesions within the carotid. And again, it's all for preoperative planning. It just provides a very nice roadmap for us. And if the patient is a stent candidate, it allows us to get much more accurate measurements, or to see if the lesion is even a stent candidate. There are many lesions that just because you can say we want to stent a patient for a high risk, sometimes they're just not appropriate candidates for a stent.
Thank you.
Dr. Choi, there's a couple of questions in the chat. I'm not sure if we're able to.
Oh, there it is. Let's see. How did they identify carotid aneurysm in the early 1800s? I'm sure they just felt a mass in the neck. Probably, but let's see for the question thinking about. So I think if you mean total near occlusion, as in, what we would call greater than 99%, standard CEA still does apply. Back to what I was saying earlier, if there are high risk features for the patient, whether they are, they have many comorbidities, or they've had neck surgery or prior radiation or stoma to the neck, depending on how the lesion looks, they can possibly be a stent candidate. So generally, we try not to stent patients with a high circumferential atherosclerotic burden. It minimizes the possibility for the stent to fully expand or to stay open, or patients with a lot of fresh thrombus in their neck. That's a higher risk for embolization. I think that's what the question implies. Yes.
I got one more question. So this NASA trial was published in 1991. Any progress since then regarding the maximal medical management? Is there any trial in the pipeline that compares maximal medical management with hysterectomy?
There are
As
many.
the medication has changed.
So there are many, and I know the whether you want to call them update or second version of the studies are still in progress. From what I've seen from many of the updates or interim, there has still been nothing quite definitive. To this day, I still question the utility of performing an endarterectomy or offering surgery for asymptomatic stenosis. Knowing the data that we have, I think how I've approached it now is just basically laying the data out to the patient and seeing what they're interested in. And it's a large procedure, and it's one of our most what's the right word, meticulous procedures that we do. But it actually carries a relatively low risk. And so what I've noticed, at least in my experience, is many patients, if they are medically fit, they would prefer to not have the overlying thought of a possible stroke in their future. But I do question to this day the utility of it, and it would be nice to have like a definitive answer. It comes down to a lot of vascular surgery where if it ain't broke, don't touch it.
Yes, Brian. Neurology. Patients with severe or 70–80% carotid stenosis within the cavernous sinus. Do you do anything about that, or was there a higher risk, or not?
I would probably refer to my neurosurgery associates for that. I usually stay I stay below the mandible. For patients with tandem lesions, we generally fix the more proximal lesions. And then if we have to do anything distally, we refer out at that point.
Okay.
I've never put a stent above C1. I'll put it that way. Or C2, C1, yeah.
There's another question in the chat. What are the latest treatments in carotid webs?
I would, I would still approach it open. The risk, well, sorry, let me phrase that. The first way is to try to do medical management, but if they are not, if it's not refractive, I would still prefer to do it open. Again, it's just a risk of rupture or dissection.
I think those were all the questions.
Okay. Well,
So we could probably wrap up now. Thank you so much for joining us.
For these patients in Kings County, do you collaborate with the vascular surgeons over at the county? Dr. Choi?
sorry, it was an echo. Sorry, what'd you say?
Dr. Choi, do you collaborate with the vascular surgeons over at Kings County?
I do not. We're effectively two separate groups. I'll be honest, I actually haven't even met anyone from Kings County. I'm sure there's some other reasons behind that, but
Oh, there's a vascular surgeon named Dr. DeRamo. He is our go-to person that does our hysterectomies over at the county.
yeah, I think he was probably my predecessor here. I've heard the name, but I haven't met him yet.
Yes. Maybe you guys should meet. May I share your contact?
Oh, sure, absolutely.
Thank you so much.
Thank you.
Dr. Choi, for residents rotating in the clinic or on the floor who are taking care of stroke patients, how can we refer patients to you?
I'll share a million ways. Inpatient, you can either call the inpatient vascular service. We're a 24/7 service, or you can email me direct. I can share my cell phone right there. That's probably easiest. And then for outpatient, again, our extension is 1981. And we have an outpatient coordinator that sets up all of my appointments. Honestly, cell phone calling me direct is probably the easiest. But we're here and we're always happy to help and assist as anywhere we can. I do hear a lot of stroke codes over the speaker all the time, so. Anything else?
Thank you so much for joining us. The history was really interesting. Thanks.
Absolutely. Thank you. Thank you for having me. It's nice meeting everyone. Take care.
Bye.